We are live.
Good evening, everyone. Welcome to the iFocus online. Today is the lecture number 10 of the Refractive Surgery module. Dr. Namrata Kabra ma'am will give us an overview of a Keratorefractive Surgery. We welcome you, ma'am, for today's session.
Thank you. Thank you, Dr. Surveen.
Today's moderator for the class, Dr. Tushya Om Prakash. He is the Chief Executive Officer at Dr. Om Prakash Group of Eye Hospitals in Punjab. He has special interest in the fields of cataract and refractive surgery, keratoconus, and dry eye diseases. Sir has received a Best Video Award in the Cataract Surgery in the IIRSI Delhi 2023 and DOS 2024. Sir has been awarded with the Gold Medal for the exemplary work in ophthalmology by the Bombay Ophthalmological Association. He has received Best Paper of the Session Award at Japan. He is the recipient of various prizes for video presentations at many conferences around the world. Sir has organized and led instructional courses at international conferences, including the AAO, ASCRS, and ESCRS. He has performed live cataract and smile surgeries at various national conferences. He has contributed chapters to various ophthalmologic textbooks and have more than 12 publications in his name. He has been inducted as a reviewer for the International Journal of Clinical Ophthalmology. Unfortunately, due to some urgent work, so will not be able to join us today. I would like to introduce the chairperson for today's class, Dr. Arvind Kumar Maurya sir. Sir has done his MBBS and MS from AMS Medical College. Sir has completed his fellowship in pediatric ophthalmology from Mahatma Gandhi Eye Hospital, Nagpur. Sir is currently the additional professor and head of the unit at All India Institute of Medical Sciences, Hyderabad. Sir is the first Indian to win the Ophthalmic Star Award at Amsterdam ESCRS 2021, AIOS International Hero Award for 4 consecutive years, 2021 to 2024, first Indian to receive AIOS Senior Academic Achiever Award 2021. Sir has received Gold Medal for Best Innovation, Best Cornea Video, and Free Paper Award. Sir has been awarded with the Best Video Award at IFFA DOS, and Sir has been conferred with 13 Oration Awards. Sir has had number of international and national presentations and publications in various conferences around the world. Sir is the Associate Editor at the UK JAWS, Sector Editor at IJO, Editorial Board, Member of EC Ophthalmology and DOS Times. Sir is the international faculty at SICSSO, WOC, ICO, and ESCRS. We welcome you, sir, for today's session.
Thank you so very much, Dr. Surveen, for your kind words. Thank you.
Today's speaker, Dr. Namrata Kabra ma'am, she has done her MBBS and MS Ophthal from Government Medical College, Aurangabad. She has an FICU in Optics and Basic Sciences. Ma'am has done her cornea training at Department of Cornea, Sankara Nethralaya, Chennai. Currently, she is the senior consultant at CFS Mumbai. Ma'am is in numerous phaco-refractive surgeries and more than 2,000 corneal surgeries up till now. She is the pioneer of femto-assisted laminar keratoplasty in West India. Ma'am has various publications in national and international journals to her credit. Ma'am is a passionate teacher and has trained long-term cornea fellows, and she is also guide to postgraduate DNB students. Ma'am has been honored with prestigious Helen Keller Remembrance Day Award for the outstanding services at Sankara Nethralaya in June 2029. Ma'am has been awarded with the International Hero of Maharashtra Ophthalmologic Society in October 2023. She's also the winner of AIOS Hackathon Innovation Contest 2024. We welcome you, ma'am, for today's session. Over to you, ma'am.
Thank you. Thank you so much. Thank you, Surveen, for your kind words.
Thank you, ma'am.
You have to stop sharing. So
Yes,
that,
ma'am.
Is my screen visible?
Yes, ma'am.
Yeah. Thank you. Thank you so much for today's opportunity. This topic is so very close to my heart, not just because I am a refractive surgeon, cornea and refractive surgeon, because uh, this is probably the most rapidly evolving field in the field of ophthalmology, I would say. More than 3 decades ago, Dr. Palikaris was the first one to perform LASIK in 1991 with a hinge flap and microkeratome, followed by excimer laser. But since then, advancements and innovations are ongoing. Uh, at one of the forum, he expressed that after inventing LASIK, he never imagined that there can be a better procedure in the world for refractive surgery. And rest is the truth. He himself was amazed to see so many innovations following LASIK. And this is the timeline which is available these days in all the literature and textbooks. And there are a number of other innovations which got added to this timeline. So first of all, let's understand why it's important to learn refractive surgeries. One is, yes, writing LAQ exam. Second, newer advances paper. Third one, Viva-Hos. And fourth one, the most important one, which is going to help you lifelong. Myopia prevalence is increasing worldwide because of obvious reasons, change of lifestyle, increase in near activity and mobile usage. Alarmingly, it's alarmingly high at n number of places, countries already. So refractive surgery is going to be up. I mean, it's going to have a surge. It's going to witness the surge. So we need to know what are our weapons in our armamentarium to fight against this enemy, this devil. So this is like Infinity War, which has begun, but we need to end this game with our weapons. We have to use them very wisely. We need to understand what are strengths and weaknesses of each procedure, the way each hero has played a crucial role with its own strength and weakness in game of Avenger. It's similar to that, I would say. So this being an overview, let's go ahead with salient features, that too, especially for cornea-based laser procedures. So we are fighting against myopia, hyperopia, and presbyopia with our weapons. First and the foremost, old is gold. LASIK, it's still being practiced. In LASIK, fortunate are those one where they can witness these refractive surgeries. But I'm sure there are so many postgraduates where the institutes or medical colleges, they don't have facility of refractive surgery. So I would also be describing procedure in brief. In LASIK, this is a cornea-based surgery where microkeratome blade, it creates a flap, it cuts a flap which is being raised, and with the excimer laser, whatever correction is desired is being done and the flap is replaced. This is heart and soul of LASIK. Just to give you a quick review, this is the video, and the blade which is moving is microkeratome. It has blade. As you can see, nomenclature, it has SR, that is suction ring. It has drive unit, and it has head. There are no financial interest, and based on models, the movement of this microkeratome can be pendular, rotatory, linear, and depending on that, hinge location would be decided. So this is just a short summary of different microkeratomes available throughout the world. So let's see, once we go ahead with LASIK, what are our strengths? What are our pluses with LASIK? Visual recovery is very, very fast. Patients, they do get wow effect day next itself. Minimal tissue reaction, less discomfort, way less discomfort as compared to PRK because we are not disturbing epithelium. Reduced stromal inflammation, no haze formation as that of PRK. Retreatments and touch-ups can be done easily. But at the same time, this is a biomechanically weakening procedure. Why? Because we are creating such a large and wide cut in the substance of cornea. At the same time, we are transecting nerve, so dry eye issue also remains. And something which is very unique for LASIK, that is microkeratome LASIK, are flap-related complications. All of you can see this speculum getting stuck with this microkeratome movement. If this happens, it will result into incomplete flap. So this is one of the unique complications of LASIK. Now you can imagine the person or patient with narrow IPF, narrow fissure, might face this problem. So you know what to select in this situation, right? Eye opening should be good enough. Then you can have free cap. What is free cap? Let's understand. If there is less tissue, so there is risk of free cap. Just to understand. And flat corneas with K value less than 41 diopter would be prone to have free caps, though incidence is quite low, but this is one of the significant complications related to microkeratome. It might occur if there is suction loss or suction is insufficient also. You can see the free cap stuck in this instrument. This is free cap video. Free cap being generated. You cannot see the hinge the way you saw in previous video. It got freed completely. That's why we call it as free cap. Second one is buttonholing. Why buttonholing happens? I want all of you to understand and pay attention to this fact here. It reminds me of my days. I used to mug it up, free cap, flat cornea, buttonhole, steep cornea during my residency days. But I was always believer of understand the fact, then you need not mug up. So just imagine tennis ball and you put a pressure, it buckles in the center. Similarly, whenever it's a steep cornea, it buckles in the center as depicted in this picture schematic. So your blade essentially comes to the surface and again re-enters. And that's how middle part remains uncut. So something which will be seen similar to this. And as steep corneas are prone for buttonholing because of its natural biological plausibility and the physics what we have shared, you have to be careful during selecting such cases. And secondly, outcome is worse with buttonholing as compared to free cap. So one needs to be aware of this complication. And there is some quick clue. There are other methods, there are other procedures which are good enough and where there is no use of microkeratome, which can be used for very steep and very flat corneas. And if there is no such option for very steep cornea, one can probably go for smaller internal diameter, and for flatter corneas, one can select larger internal diameter. This is again a video of partial buttonhole. So because of these microkeratome related unique problems, advent of femtolasic was welcome throughout. In this procedure, the flap creation is being done with the help of femtolasers, 10 raised to minus 15. These lasers, they create multiple points of vaporization which results into bubble formation and cut. But there are septies which needs to be broken during dissection, and you can lift the flap. The rest of the procedure remains same. As blade is not being used in this procedure, this is bladeless. And flap-related complications would be way less than LASIK because microkeratome is the main culprit. Flap morphology is planar in femto-LASIK as against LASIK, where non-planar. That does mean in the periphery, the flaps are thicker, and in the center, they are thinner in case of LASIK. So in femto-LASIK, flaps are planar. Hinge location can be customized. You can keep hinge location anywhere. Flap thicknesses can be customized to any extent. It has less risk of epithelial ingrowth, and the suction created during ring application is way less than what is being achieved during LASIK or what is being essential for microkeratome LASIK. So what are unique complications of femto-LASIK? It comes with the problem of opaque bubble layer. You can see in this picture, opaque bubble layer. Opaque bubble layer is nothing but accumulated gas. As we have discussed, it causes vaporization and then, gas formation. So this is accumulation of gas. And whenever there is opaque bubble layer, there are two ways one can deal with it. One can wait. As it is gas, it gets absorbed in a couple of minutes, or else one can nudge it with the help of blunt dissector, and one can try to disperse it. Other complications like transient light sensitivity syndrome, rainbow glare, and diffuse interstitial keratitis were high as compared to LASIK to begin with, because amount of energy used in initial femto-LASIK machines were way higher. With the advent of second generation, third generation machines, fourth generations, the amount of energy went down, and these complications are no more. They don't pose any additional risk. In spite of femto-LASIK, it's a flap-based procedure. Being flap-based procedure, it runs risk of dislodgement of flap, especially if your patient is into contact sports. Say if patient is a boxer, if patient is into martial arts, if patient is into any kind of contact procedure where contact sports where it runs risk of direct injury, flap dislodgement can happen even in late cases. So what comes handy for helping us out is SMILE. So SMILE is the procedure which is flapless, where small incision is created. A lenticule is created with the help of femto-LASIK. Instead of photoablation, the equivalent amount of lenticule is being extracted for the desired refractive correction. So this has no flap, as you can see, and the name itself is explanatory. It's a small incision procedure. Being small incision, it transects less number of nerves, so less amount of induced dryness. No flap related complications, obviously, because there is no flap. Better biomechanical strength, because we are cutting less amount of cornea. Regarding higher order aberrations, there is controversy because some of the papers, they say it induces less amount of higher order aberrations, whereas some of the papers published, they claim exactly opposite of it. So I would like this point not to be highlighted in view of. And lower suction IOPs as compared to LASIK and femto-LASIK. So this is how SMILE procedure is being done. The initial part is known as docking. Docking is very soft because the amount of pressure created is very, very low. It doesn't compress the cornea to make it planar. It's a convex cup or cone which is being used for the sake of docking. What are cons? The learning curve for SMILE is steep. There can be incomplete lenticule extractions. There can be iatrogenic stromal scarring, interface irregularities. Eye tracker is not available, particularly with SMILE, though now there are newer advances. Hyperopic treatments are not available, and only high astigmatism cannot be addressed, and cost is another limiting factor. You can see here in this ASOCT is showing retained fragment, retained lenticule. And these are a couple of those papers as I had discussed. SMILE, and now we have something we keep hearing every day, it's silk. Silk is also a similar platform where lenticule extraction is being done, and these are some of the finer differences which you can refer. But I would like to all of you to be clear with the concept that nowadays many of the societies, especially scientific societies across the world, they have declared here onwards they are not going to accept the terminology silk, SMILE, etc., etc. Why? Because these are all proprietary names. So what they have come up with is a terminology is KLEX, Keratorefractive Lenticule Extraction. So don't get confused if in exam the question being asked is what is KLEX or describe KLEX. All these procedures will come under it. With different manufacturer, they have labeled their procedure differently. Like we have SMILE, silk, clear, and smart side. But all the platforms, they utilize same principle, that is lenticule extraction with finer differences. Those are proprietary differences. So these are a couple of options available commercially. Coming to PRK, though this is not the newer advance, but this has kind of transformed and there is a resurgence of PRK, better I would term it as. PRK initially was kind of option which had come with major risk of haze. And with the advent of mitomycin C, now PRK is being talked a lot and being practiced a lot because of its obvious benefits of being flapless. In PRK, epithelium is being removed. There are different ways to remove epithelium in PRK. One is alcohol-based removal of epithelium. Alcohol loosens epithelium from its basement, from vomits, and you can separate epithelium. Then other one is mechanical debridement with the help of any blunt instrument or a hockey stick knife. Third one is Amoy's brush. With the help of suction, it removes epithelium. And fourth one is trans-PRK. With the help of lasers itself, you can remove epithelium. So this is epithelial removal. Later on, the excimer laser part remains same. But as here we are removing epithelium, patient, you can expect pain. Pain would be more than any other procedure in case of PRK. Technically, PRK is very easy to perform. It is flapless again. This is a very good option when it comes to thinner corneas. And as we discussed, any sport where flaps are not desired or very narrow fissures. As we have already discussed, discomfort and postoperative pain is a major concern. It takes little longer for visual recovery because epithelium takes a while for healing. And during that time, bandage contact lens is being used for patient comfort as well as promoting epithelial healing. It takes little long for tissue remodeling in case of PRK. And as we discussed, risk of haze formation is there and chances of regression. It's something which is unique for PRK, and this is gradation of haze. In lieu of time, we won't go into details of it, but you can see this is how post-PRK haze looks like. And here is a meta-analysis of 11 randomized controlled trials, which says use of mitomycin C prevents corneal haze very effectively. And all the studies, they have reported the efficacy of more than 90%. Just to complete the list, because for examination point of view, especially theory exam, you might have to write regarding LASIK and epiLASIK. Though these are practiced little less these days, you need to understand what's the difference between LASIK and epiLASIK. I'm so sorry. One of the picture I have inserted is not coming up. But in case of epiLASIK and LASIK, the flap created is very, very thin. It is within the epithelium, as against LASIK where it is within the stroma. And in case of LASIK, alcohol is being used to loosen the epithelium. And in case of epiLASIK, we can use the instrument being used is oscillating plastic blade. Sunilji, I am encountering some technical issue. Yeah, resolved. Thank you. Thank you so much. It's responding very late. Sunilji from technical team, am I audible to you? My slides are not moving.
Yes, your slides are moving and you are audible.
So they are moving for you. It's not moving for me. Like I'm stuck with this slide. I am unable to go back. Just a minute. Sorry for this technical glitch. Yeah, fine. So this is PK Kyle, though today's topic is keratorefractive, but yes, one needs to understand this as well. This is one of the option where, especially for LASIK rejects, where cornea is very thin or very high refractive errors, and it has got its own pluses and minuses. And dryness issue because of nerve transaction is not there in case of phakic IOLs. And there are a couple of issues with the phakic IOL, risk of endophthalmitis, loss of endothelium, or decrease in endothelial count, cataract formation, raised IOP, and it also requires prerequisite ACD. That is, anterior chamber depth has to be adequate. Most of the literature, it quotes more than 3 mm, and some of the literature, it also quotes more than 2.8 mm for myopic patients. For hyperopic, it is strictly more than 3 millimeter. Here comes refractive lens exchange. For very high refractive errors, this also can be one of the options, but one needs to understand it also runs risk of endophthalmitis and increased risk of retinal detachments. These are intacs. Intacs, though used these days for keratoconus, were initially advented to be used in case of myopia. So for theory examination, you need to know these options. Corneal inlays is also one of the options. You can see complication as well along with corneal inlay. This is camera inlay. Camera and raindrop inlays. These two inlays were used for more than a decade. And nowadays, very few practitioners, or this is no more being done because of its high complication rate. Different sizes are being available. Allogenic corneal inlay is also one of the options where you can see allogenic tissue has been inserted, and the initial results which are published are encouraging, but of course any allogenic tissue will also have its unique complications or issues, post-op problems. This is stromal enhancement procedure. The lenticule which is being removed to smile. The idea generated this way. The same lenticule was being inserted for patients of hyperopia, and this can be one of the options for treating hyperopia, though results are not repeatable at the moment. There are no nomograms available, but this is one of the procedure which you can consider writing your advances paper, I would say. And this is bioptics. What is bioptics? When it comes to very, very high refractive error, then probably your enemy or the devil you might not be able to knock it with one hero. So second hero has to come into play. So you can go for ICL, that is phakic IOL, and you can also add on PRK if it's very, very high. This is just to summate whatever we have discussed. This enlists all the advantages and disadvantages of individual techniques we have discussed so far. And these are a couple of things which I wanted to add on in view of exam. Conductive keratoplasty is one of the options to treat presbyopia, where the radiofrequency energy is delivered through a fine tip in periphery of the cornea in ring pattern. And you can see the histopathological changes it induces. This is also one of the newer treatment where the multifocality of cornea is created with the help of PRK. This is a new platform and new treatment available with one of the platform at the moment, but one should be aware of this as an option for presbyopia. The long-term results are still awaited. And this is like to discuss peculiar situations. Say if it is how you select, if it's thin cornea and along with that high myopia, what are your options? You can go for PRK, you can go for phakic IOL. If it is hyperopia, if there are lenticular changes, then you might abandon all cornea-based surgeries. You might select probably refractive lens exchange. If there are higher order aberrations in the lens and not in the cornea, what you would select? If it's post-operative curvature, if it's too flat or too steep, it might induce higher order aberration. In such cases also, your choice of procedure might change. And this is again for your newer advances paper, the procedure known as corneal photovitrification, where cornea-based refractive surgery is being used to treat age-related macular degeneration. What is being done is 4 points of laser function is being utilized to shift the focus and focal point of the affected area. And the initial results have been published. They are encouraging, but larger studies, more studies, and results are awaited. And this is how there might be change in topography. These are my references. These are some of the good reads as well. Thank you. Thank you so much. As it was an overview, and all the topics subsequently will be discussed in detail. So I have kept myself to salient features.
Excellent overview, Dr. Namrata, and many congratulations. You covered all the entire paraphernalia and covering most of the details.
Thank you. Thank you so much, sir. Sir, I would request you to add on whatever you feel
Yes,
like.
let's see what are the questions. Surveen, do we have questions? Kratika?
Hello.
Hello,
Good
ma'am.
evening, ma'am.
Yeah, evening.
Ma'am, when we speak about extra procedures, which one would be a better option, an extra procedure or an ICL, ma'am?
Extra procedure is being done for weaker corneas. There are proponents of extra procedures, but if you ask my perspective, I would prefer phakic IOL. But I guess this platform is not sharing my perspective. The scientific studies, they say if cornea is weak, then you cannot predict how much of biomechanical strengthening exactly is going to happen post CXL. That cannot be predicted or controlled for that matter. This is not exactly CXL, but extra procedure, the principle remains same. So ICL any day or phakic IOL would be, for that matter, is choice in all such cases. If cornea is inherently weak, it should not be, it should not face any cuts.
Okay, ma'am.
Also, when we go for ICL or phakic IOLs in such cases, so the ectasia or the astigmatism or the keratoconus, it needs to be stabilized because we will be implanting the toric phakic IOLs. So that needs to be stabilized before we are going for this procedure.
Very true. And in case of like initially what I addressed was presuming these are normal individual, non-keratoconic. But if a patient or person is having keratoconus, labeled keratoconus, then cross-linking to stabilize keratoconus, and post cross-linking, there are n number of studies that stabilization of contours might take as long as 2 years. So most of the studies, what they are saying is it's ideal to wait for 2 years before going ahead with phakic IOL surgeries for any keratoconic patient.
Also, we need to look for the subclinical, sometimes the, this, yeah, ectasia is subclinical. So this 4-map, this reference mapping is very important before opting for any procedure.
True.
It is very helpful.
Yeah. That was another class, dedicated
Yeah,
class.
so I'm not going into the
Yeah.
details. Definitely not.
True.
Also, the patients of VKC are very common in the Asian region. So they have suboptimal inflammation all the time. The osmolarity, the MMP levels. So there are a lot of things to consider.
Yes, sir, you have very rightly pinpointed. We being Asians, we have different prevalence. We are definitely having way high prevalence of keratoconus. We are having higher prevalence of VKC. And inflammation is the sole reason behind keratoconus, which is being proved these days. We need to consider surface treatment and getting controlling inflammation before planning any refractive procedure for that matter.
Absolutely. We
A
need.
very good point, sir.
Yeah.
Ma'am, there's one question, a very basic question, I would say, but we have been hearing about silk right now. So I want to basically know the differences between a smile and a silk procedure. The basic differences.
And silk procedures, both are lenticule extraction. When it comes to in principle, so that is a common thing, and especially for postgraduates, I would say. Yes, when it comes to differences, you need to understand differences. There are a couple of differences. The first and foremost is silk uses less amount of total energy than or as compared to smile, and the lenticule shape is different. Lenticule edge configuration of lenticule is different, and silk, we do have cyclotorsion compensation, which is one of the most important feature of silk, which is not present in smile Vijumax 500. But then, it's difficult. Now with their Neo machine, they do have that cyclotorsion compensation as well. So this was difference to begin with, but with the Neo machine for smile as well, they have this incorporated. And couple of finer differences. Even after docking, you can change the centration part in case of silk, which cannot be done in case of smile. So these are all finer differences, I would say. Sir, would you like to add anything
Yeah,
from
yeah.
your?
So definitely. So the minimum energy and they are also treating the spot size is much smaller as compared to
Yes,
the smile.
their cell energy,
Yes.
and that's why, and their number of septies is very thin, basically. So dissection is very smooth as compared to smile.
And now coming to the cost wise, so it is further costlier than the Smile machine, and it doesn't have a recording system. That is a main drawback because if you want to teach the residents, so it doesn't have the recording system. That is a main drawback. I have no financial interest.
Yes, sir, I too have no financial interest. One good part with silk is machine is compact.
Yeah.
So probably the space required for machine is also less. But these are differences which won't be probably pertinent for postgraduates. That's why I'm kind of, not highlighting these differences.
Okay, ma'am. Ma'am, any differences in the higher order abrasions between silk and smile?
It's too early to comment, I guess,
Mhm.
because we need to have n number of papers to comment on this, because silk, it is claiming that higher order aberrations are way less than smile, but probably long-term studies are required. To begin with, I remember smile, they used to claim the outcomes, biomechanical strength is way better than other procedures. But later on, with long-term studies and number of studies, meta-analysis, what we realized is at 3 months, all these procedures, they give equivalent result in terms of visual acuity outcome as well as biomechanical strength. There are a number of papers which claims actually that it might be comparable. Of course, there are different papers claiming different things. So we need to wait for a while for that. But as of now, yes, the higher order aberrations induced with the help of with a silk are less than smile is what is being claimed.
For higher order ablation, we can always opt for wavefront guided ablation. That is the preferred choice, and it's universally accepted.
Yeah, so she meant induced higher order aberrations. Am I right, Survin? Yeah,
Yes,
and as
ma'am.
he rightly pointed out,
Yeah.
if there are higher order aberrations pre-existing, then wavefront is the answer, the key.
Okay, ma'am. Ma'am, we have a few questions. Um, what is the preferred refractive surgical procedure for eyes with cornea less than 37 to 38 diopters, and for the one with more than 48 diopters? What will be the preferred refractive surgical procedure?
It also depends on amount of refractive error. Say a patient has 38 diopter with 7 diopter of myopia to treat, then probably will the option selected would be very different. So it depends. I mean, this cannot be considered in isolation. Say 38 diopter patient and patient has -2 diopter myopia, then femtolasic can be done because less chances of free flap. Smile can also be done. PRK can also be done. But say 38 diopter patient with -8 diopter of myopia, then the resultant actually induce additional higher order aberration. In that case, this patient should be considered for phakic IOL. So it depends on other variables, but yes, LASIK won't be choice in situation, whatever situation you have given. Either it's very flat cornea or very steep cornea.
Right, ma'am. There's another question. Is there any contraindication, or should we make any adjustments in surgical parameters when it comes to pupil size?
Yes, definitely. It's very, very important. We are blessed that way because Asian eyes, our pupil size is not very big one. But just imagine uh, pupil is very large and we have corrected a small zone, say smaller zone than pupil and especially scotopic pupil, then patient will have a transition from where patient will have so much of glare and halos. So our optical zone should be more than scotopic pupil size. That's why it's very, very important to measure pupil, and that too in mesopic condition. Basically, mesopic conditions are very, very important, but we need to know scotopic pupil size as well. If it's abnormally large, then our choice of procedure might vary.
So in larger pupil, if it is more than 6 millimeter, we can opt for a smile and silk because they have a larger zone. And in the hyperope, because if they have a small cornea, then we can go for PRK.
Yes.
Okay, sir.
Usually, hyperopes will have smaller pupils as well, and myopes.
Yes.
So that is one more boon for us. Otherwise, everything is bane, I would say. For hyperopes, there are so many limitations. ACD, usually anterior chamber depth with hyperopes is less. Uh, Very rarely they are candidates for phakic IOLs.
Absolutely. The ACD, the effective from endothelia to the chamber depth, it needs to be more than 2.8. We need to minus the CCT.
Yeah, thank you so much for bringing that point up, sir. Whenever you see ACD being measured by any instrument, you need to ensure whether CCT has been taken into consideration or not. What we require is aqueous depth, like endothelium to lens. And different machines, they have different settings to measure. Some of them, they consider corneal thickness, some of they don't. So you need to know your machine as well.
Okay, ma'am. Ma'am, one thing, when we do any silk or smile procedures, there is a we do a centration. So do we take the pupillary axis or the visual axis? The centration should be according to what parameters?
See, pupillary axis and visual axis. If there is gross difference in that, which translates into wide angle kappa, then these are not good candidates for silk or smile. So this procedure won't be choice of procedure in such cases. Why? Because in these patients, we don't ask patient for fixation. So we tend to get decentered treatments. So this is really a very intelligent question, I would say, Survin. Thank you so much for this question and bringing up this point.
Also,
So
Surveen, because
consider,
all these devices, they work on the pupillary tracking methods, right? So never to, because there are a lot of studies coming up, never to instill moxifloxacin because it pushes the pupil eccentric, right? So never to start instilling moxifloxacin because they
Okay,
work on
sir.
the pupillary tracking devices for the centration and for the greater outcome.
this is very interesting, sir. I was not
Yes,
aware of this.
yes,
Though
you can go
this
through.
we
Yeah,
use
literature is available.
antibiotic. Yeah, we don't put as it is moxie beforehand, but very interesting. I was
Yeah,
not.
just for the sake of knowledge, for
Yeah, yeah.
of
Thank
sharing.
you so much for sharing this.
Any more
Um,
questions, Surveen,
uh,
Ritika?
no, sir, we don't have questions right now.
So I request now Dr. Namrata Kabra to for the end note, the concluding remark.
In conclusion, I would like to just sum up with the fact that we do have n number of options these days. The LASIK terminology, which once upon a time used to equate to refractive surgery, is no more a fact. Now we have so many weapons in our armamentarium. We need to know pluses and minuses of each thoroughly so that we can use all of them and any of them very wisely, intelligently, and for offering best outcome for our patients. And thank you, Dr. Moria, for being with us and sharing your insights with us. Thank you, Dr. Surveen, for coordinating this seamlessly. Thank you. Thank you, iFocus team, for this opportunity. And all the
Thank you,
best to
ma'am.
all the postgraduate students.
Thank you, sir. Thank you, ma'am, for this wonderful class.
Thank you.
Yes, sir. Thank you, ma'am.
So I hope the postgraduates and fellows, they must be enlightened with a lot of the perspectives and the different methodology for this keratorefractive procedure. So never to rush. The proper examination is very important. The small things like evaluation of dry eye is a must before going for any procedure. And if the refractive power is too much, then the phakic IOLs, they are the best choice. So thank you, Dr. Namrata Kabra, and thank you, iFocus, Dr. Santosh Unava, Dr. Maipal Sasdeva, for giving us the opportunity. And all the very best for all your future lectures and endeavors. It's a great
Thank you,
platform.
sir.